died in the middle of the procedure, or in the middle of the procedure. So I obviously decided to take an imaging spin on you guys at the conference and an imaging fellow. So I just wanted to kind of highlight two different diagnoses that really have a beneficial role of CMR in them. Obviously, historically they were diagnosed without CMR before they became more prevalent, but now with CMR, just kind of showing you where the added benefit can be seen. So the first case is a 27-year-old male. He has a past medical history of ADHD. That's pretty much it. He has no past cardiac history. And he presented to the ED with chest pain. This was back in 2006. He was a non-smoker, occasional drinker. He exercised frequently and started noticing that he was having some continuous chest pain when he was exercising. So here's his EKG. Nothing, things notable, sinus bradycardia, and then you see this kind of two-way inversions in the precordial leads, 1 through 4. And so I'm going to be honest, this isn't really his echo because his was from Southdale and we weren't part of Fairview. They weren't part of Fairview at that time. So this is just an echo that was similar in description. And as you can see, the right side looks pretty big. The right atrium looks enlarged. Your right ventricle looks enlarged. Doesn't necessarily look terribly hypokinetic, although you can't really delineate the RV free wall that well. The LV looks probably normal, and the left atrium looks okay. This is just another image. This is your peristernal short axis at the base of the heart. You can see your aortic valve. You're catching the tricuspid, and then here's where you can measure your right side, and it just kind of looks sort of dilated there. Here's your inner atrial septum, so your left atrium, right atrium, tricuspid, right ventricle, and RVO2 right here. This is just another image. So this is the peristernal short at the mid-level, so you're catching your mitral valve. And then here you can just kind of appreciate, again, the RV enlargement. Again, this isn't this patient, so you see this thing flipping around in it. This patient actually had an ICD, so that's what that is. So based on this 2006 echo, with the RV enlargement, there was more hypokinesis, I think greater than what was shown on this particular echo. And he had some thinned walls, which I would say is hard to kind of really note on echo. As you can see, we can't really see the RV free well all that well on an echo, but regardless, they said he had some wall thinning, so he was deemed as likely having ARVD. And so at that time, we did have cardiac MR, so they sent him for cardiac MRI to confirm the diagnosis. Bill, do you want to go to the MRI?
So this is a 4-case review. What you can see is that the RV is partially dilated, the walls slightly side, and the RV comes down the roof. RA is we basically go under the LA. And we will find the LV, I'd say we have to visually, I'd say like no obvious territory, even look at that on the right side. Lungs look fine. I don't think there's a thorough
Yeah. So I think that's a fair assessment. So something to note is like, you can see your TAPSE just doesn't look that vigorous. So you're not normally looking like 1.5, 1.7, and it just doesn't look to be that vigorous. Also, this free wall, if you really look at it, things are moving, but is it actually kind of getting smaller? Not necessarily. And then you've got these little outpouchings in the free wall. Here you can see towards the apex. Here again, you can see close to the mid cavity, and that truly the apex of the RV shapes the apex of the heart. So that tells you it's dilated, and this tells you there's some akinesis and dyskinesis of the RV free wall. So again, this is, Phil, you want to just continue reading?
This is the long axis view. That's the CAD review. You kind of get a little piece of the RB, maybe a little bit more of RB, maybe a little bit of RH. Don't forget the say and the AI. Obviously, LMR. There's not so many things. Wall. I don't know. Is there a lot of walls as well? Not really.
Maybe a little bit hypokinetic.
RB is
Maybe a little big. Yeah, so it just shows that it's a little big. Here's your RVO flow. So here you can see, this is a view you don't typically see on echo. So here you can see, this is really focused on the right ventricle. And you can see the pulmonic valve will be somewhere here, and then this is your pulmonary artery. So this just, again, just highlights how large the RV looks, and that it just doesn't look like it's really contracting all that well. So these, I'm sure you guys are all well aware of the circles that we've drawn. So this is just the way that we get our volumetrics on cardiac MRI. So you basically cut the heart from the base to the apex, and then you measure the area, and then you add these together, and you essentially get a volume. So the big limitation with echo is that it really there's a really hard time delineating the RV, and so then it's hard with the shape of the RV to actually get a true volume. And like 3D echo, I guess, helps with that. But in general, echo has a hard time delineating how large the RV is, especially when you're truly trying to look at volume. So this is can be really helpful in the assessment. And then this is the delayed enhancement. So this is your late gadolinium enhancement, where you're waiting between 10 to 20 minutes, and you're looking for areas that are bright where the gadolinium is accumulating, which typically means infarction or increased extracellular volume. So here you can see along the free wall, it just looks brighter compared to if you look at the LV myocardium. And again, you can see this rim of bright along the RV free wall. So it's not always seen in ARVC, but it can be. So obviously this isn't a huge lecture on ARVC. You guys are probably very familiar with the disease and things, the aspects of it. This is supposed to more highlight where the imaging role comes into play, and echo possibly shortcomings, and where the benefit of MRI can stand. But just a little bit of background. So it's a genetic form of cardiomyopathy. There's autosomal dominant, autosomal recessive, and those are the list of the genes. Typically, the mutation is with the desmosomes, which are the cell-to-cell connection. There are, again, these recessive mutations, and this is that when you study for boards, you'll see like the islet of Naxos, and that's where that really comes into play, is the recessive form of it. So the mutations cause the desmosomes to be inappropriately sensitive to stress, which results in myocyte death. So a lot of times when you think of your classic example, and I think it was actually a board example this year, where this girl was having syncopal episodes while she was running, and they kind of tried to trip you up. The first time sounded like it was truly vasovagal, it was really hot out, but the second time was unprovoked. And then they showed you an image of the echo, which shows the RV being extremely dilated and hypokinetic. So you're supposed to kind of decide what management happens next. So this will come up, just knowing the clinical context of this is when patients a lot of times exercise. I'm so sorry. This again, so like I said, this is an abnormality of the desmosome. So here is an example of kind of what the desmosomes are and what their role is. So obviously there's supporting structure with cell-to-cell adhesion, and then they also regulate transcription. They form the gap junctions, and then they also actually have a role in the calcium hemostasis. So they actually have a few roles. And then the natural history, so usually presents early. So a lot of times we'll do an ARVC protocol on patients when they come in with PVCs, unexplained syncope, but I think our yield is fairly low, especially as the older the patients get, because they have so many other reasons to have these symptoms. But so patients present between their teens and their 40s, and the prevalence is, some papers said 1 to 1,500, 1 to 3,000, 1 to 5,000, so about 1 to 3,000, and the male to female ratio, so it's higher seen in the females. So like I said, the board's question was a young female who was out for a run. And there's really 4 phases. When we think about this, it's the concealed phase, where patients are at increased risk of sudden cardiac death, but they're asymptomatic. There's the overt clinical phase, where you get expression of the electrical system disturbance. So this is where you can see it on the EKG. Signs and symptoms of RV failure, and then frank biventricular cardiomyopathy. So this is the 1994 kind of criteria that were used to diagnose ARVC. And so at this time, the thought process was that this was truly a right-sided heart disease and that the LV was not involved. And it was mostly based on your EKG findings and on your RV morphology based on echo. And here's the 1994 task force. So these are the different aspects that we're focused on. So regional dysfunction, so this is obviously your imaging component. So severe dilation or reduction of the RV ejection fraction with only mild or no LV impairment. So again, this was thought to be a purely right-sided cardiomyopathy back in 1994, and then localized the right ventricular aneurysms, akinetic or dyskinesis. So we saw that on our MRI image of our patient where they had these little aneurysms in the free wall. And then severe segmental dilatation of the right ventricle. And then, so there's major and minor criteria for each aspect. So then tissue characterization obviously was something that was on biopsy or after the, an autopsy. So basically fibrofatty replacement of the myocardium on biopsy. And then the repolarization and depolarization abnormalities. So those are mostly EKG findings. So this is that inverted T waves on the right precordial. So we saw it on this patient's 2006 EKG that the T waves are inverted in V1 through V4. This really highlights V1, V2, and it has to be in patients who are older than 12 years just because they can have subtle abnormalities that are different than adult patients. And then again, the highlight is in absence of a red bundle branch block. And then for the depolarization, looking for epsilon waves, and I'll show you an example of what they mean when they say epsilon waves. And then arrhythmia. So when you're thinking of arrhythmia from RVO, from the right side, you're going to have a left bundle branch morphology for your VT. And this can be on Holter, on event monitor, or even just on an ECG. So, and then family history. So obviously, if you have a family history of a confirmed diagnosis, that definitely is a major criteria. And then there's minor criteria, family history of sudden cardiac death in somebody less than 35, what's due to suspected right ventricular dysplasia. So a lot of patients, especially back then, didn't necessarily have an autopsy, but if you have enough patients who've had a family history of sudden cardiac death, you start to wonder.
What is genetic?
So at this time, genetic testing wasn't that robust. So this is the 1994 criteria. So yeah, genetic testing was kind of the missing piece, and we know genetics actually plays a role into it. But then again, there's the different phases also. So the concealed phase, and then some people may be negative and have it. No, so I'll go. There's the one major, excellent minor. So this was just an example of an epsilon wave. So you can see that kind of upward dipolar flange here at the end of your QRS complex before your T wave. Here you can see the hallmark T wave inversions. This one goes all the way up to V5, but typically it's V1 to V3 up to V4. So again, our patient had up to V4, but you can see that little bump here, and that's what's considered your epsilon wave. So that's when they were talking about that, and that I don't think showed up on boards, but it was definitely on a lot of like practice tests. To answer Shadi's question, so what do you have to have everything? Do you have to have nothing? So it was 2 major criteria, 1 major plus 2 minor, or 4 of the minor criteria to actually make the diagnosis. And then this is just an image from that original paper of a 39-year-old male who was diagnosed with ARVC. You can see the anatomic specimen, so you can see the fat on the walls, and then the histologic specimen, you can truly see adipocytes replacing the myocytes in the RV free wall. So the 1994 International Task Force proposed the criteria were deemed to be highly specific, but they lacked sensitivity. As you can imagine, it was really hard to make the diagnosis, especially if you didn't have classic features, and family history is tough because, again, patients don't necessarily know their family history, or they didn't have an autopsy, so they don't actually know why their family, passed away. So in 2010, they updated the criteria. So that's what I wanted to kind of highlight, was where we've gone from 1994 to 16 years later. So this is the diagnosis of ARVC, and this is the proposed modification of the task force. So this is what we use. Those of you guys who have done MRI and we're doing our patients for ARVC, you guys have kind of gone through the criteria, and we sort of break it down to see from an MRI standpoint, what are we looking for? And there's some interesting aspects of that. So I've highlighted the MRI thing. So in the left column is the original task force from 1994, and then the right column is the revised. So you can see it's a little more detailed, and it's a little more cut and dry, and not so kind of blasé and vague. And again, there still is the major and there's the minor criteria. So the first is looking at the global or regional dysfunction. That was the first kind of aspect focused on. And so you can look by, originally just said severe dilatation and areas of akinesis, and it's very vague. So this one actually breaks it down into 2D echo and MRI. So obviously, we focus on the MRI criteria. So regions of RV akinesia, dyskinesia, or dysynchronous RV contraction. So that's pretty similar to what the other ones were, and we can see those on a lot of our imaging, our dedicated RV views, and we can see it on the 4-chamber. And then in addition to that, it has to be one of the following. So this is where our circles or triangles, I guess, for the right side actually means something. You're looking for your end diastolic volume when you're indexed to the body surface area. To be greater than 110 in men and greater than 100 in females, or your RV ejection fraction to be less than 40%. So that's your major criteria from an imaging standpoint or from the functional standpoint. And then your minor criteria are similar in that you still need that areas of RV akinesia or dyskinesia, but they kind of lighten up a little bit on your end diastolic volume. So for a man, it's greater than 100 but less than 110, and then for a woman, it's greater than 90 but less than 100 when indexed to the body surface area. And then your RVF is between 40 and 45. So that's really all it is for MRI criteria. You don't see anything about your fatty replacement when we do dedicated imaging to look for fat in the free wall. You don't see delayed enhancement. None of that seems to be in the revised criteria, and there's reasons why. So at this point, it's purely based on function, and it's purely based on volume. So again, going back to our image, here you can see again, just to re-highlight, this just doesn't look like the function's that great. It looks large, and when you do the volume, when indexed, it came to 156. So obviously, definitely makes the criteria because it's greater than 110 when indexed to the body surface area. And then you've got these outpouching. So just based on those two things, you'd say, okay, this patient has ARVC. You could, because based on the criteria, right, you are just looking for function, which we look at for all patients, and you're looking at volume. So in theory, you can. So the dedicated stuff, one is the 4-chamber stack as part of our ARVC protocol, and that's truly to see all aspects of the free wall to see is there any areas that you might miss, because this is a one-plane view. You're only seeing if this is outpouching. If we would have cut maybe a little bit above it, you might have missed it. So that's why we do that. But then, yeah, there's other aspects that we do for the ARVC protocol that aren't necessarily in the guidelines or utilized in the guidelines to make the diagnosis. So the other aspects, just like we had talked about in the other, so tissue characterization before, it was just kind of blanket statement, fibrofatty replacement of the myocardial on biopsy. So this broke it down a little further in the new criteria. So residual myocytes less than 60% with fibrous replacement of the RV free wall myocardium in greater than 1 sample. So realizing that when you do your RV biopsies, typically you're going to biopsy towards the septum, which isn't really where this typically affects. It's usually in the RV free wall, and you run the risk of perforation when you biopsy RV free wall. So biopsy maybe isn't the best, plus it's segmental, or it's kind of in pieces, so you could biopsy an area and say, okay, great, it's negative, but that doesn't necessarily mean you've completely ruled it out. Repolarization, again, EKG is still important, and this is looking at your inverted T wave in V1 to V3. And this brings the age bracket up to 14 years old. And again, in the absence of a right bundle branch block or a QRS that's greater than 120. And then the depolarization abnormality, so the epsilon wave, so we showed you what that is. or lay potentials on signal average EKGs. There's a lot of different EKG depolarization criteria. Arrhythmias, so sustained or non-sustained, again, still needing the left bundle branch morphology because that means it's coming from the right side. So that usually means negative in 2-3 AVF. So it's coming from the free wall, so it's going to be, the depolarization axis is going to be going upwards or northwards, so it's going to be actually negative in 2-3 AVF, where you typically see things being positive. It'll be positive AVL because the vector of depolarization is going to be heading towards the left because it's coming from the right. And then family history, again, still important. ARVD confirmed in a first-degree relative who meets the current task force criteria is definitely a major criteria. Yeah, so it kept it very similar between the 2010 and the 1994, but it just sort of broke it down a little more and made it a little less vague, and then incorporated MRI, which is a big difference between the prior. And so this one, again, 2 major or 1 minor, or 2 minor, 1 major and 2 minor, and 4 minor. So that was a definite, then there's borderline, and there's possible. So this was just an original article. This was from back in the 1990s that I found, and it was cited in a few different texts that I was reading. So it just looks at kind of our MRI features of ARVC, and so it was really only done on 30 patients who were analyzed between 1994 and 1995 who had suspected diagnosis of ARVC. All the patients had serial EKGs, echoes. Some of them had angiography, and then everybody underwent CMR. And the following features were looked at for the diagnosis of ARVD. So the presence of a high signal intensity, indicating substitution for fat for myocardium. So like we said, fatty fiber replacement of the free wall, ectasia of the RVOT, dyskinetic bulges, dilation of the right ventricle, and enlargement of the enlargement of the right atrium. Dilation of the right ventricle, of the RVOT and ectasia basically just meant that it was larger than what the LVOT was. And this was the 30 patients and their breakdowns. We obviously don't have to go through all the aspects of them, but you can see when looking at these 5 different aspects, those who had highly probable had usually 4 out of 5, 3 out of 5. I don't think anybody had 5 out of 5. But those that were negative usually had 1 to 2. So just when you're focusing on it, it was mostly men in this, I think it was 22 men and 8 women. And these are just a few images. This is the one on the left is your short axis, and then your 4-chamber. And this is looking at your fat substitution of the RV free wall into the myocardium. So here you can see this is bright. So just like they had said here, presence of high signal intensity areas indicating substitution of fat for myocardium. So here you can see the myocardium clearly is dark in the LV, but then you've got this bright myocardium on the RV free wall. This is an image of your RVOT, so you can just see how dilated your outflow tract is. So that would be one of the criteria they had looked at. This one is looking just at the right atrium, and there's that fat substitution of the right ventricular free wall again, but just saying that the right atrium needed to be enlarged. Then this is your short axis, and you're seeing it, so you can see these areas of bulging or dyskinesia and ventricular aneurysm. So this was just kind of a paper I looked at that was focusing on the sensitivity, specificity, and inter-observer variability. And basically, the end result of this paper was that the sensitivity and specificity were between the 70s to 80s, and that the qualitative assessment of the RV structure was pretty reproducible amongst people who read MRI frequently. So take that for whatever that means. And really, among these parameters, looking for wall motion, looking for areas of bulging, that was very reproducible, but things like fat infiltration lacked a little bit of reproducibility. Somebody might say there is fat infiltration, other people might say there's not. So, but just showing that MRI can be a benefit, and it can accurately, help with the diagnosis. Then the other thing is obviously ARVC. If patients are presenting in their teenage years, they probably have they've had this deformity or genetic issue their entire life. So the importance of, using these criteria, how do they work in children? So we know they work pretty well in adults, but how about in children? So the aims of the study were they wanted to see the CMR findings, the prevalence of CMR findings in children, and assess the importance of CMR and other components of the revised task force in the diagnosis. So obviously they did the same imaging that we always do, cine imaging, where you actually see the movies playing, short axis, basically everything that we typically do, and then they were assessed for fat infiltration and fibrosis. And really, again, this is just a reiteration of what the actual criteria. So they used the current task force, and they basically broke down the patients. So there was here's the patient demographics. It didn't really differentiate all that much between the different groups. And they were broken down to between definite or borderline. Those were kind of considered positive to have ARVC, and then possible and unaffected. And those are the patients who were deemed to not have ARVC. So as 142 patients, 50 did not have ARVC, 37 had possible, 32 had borderline, and only 23 had definitive. And basically, in the end, what they showed was that the echo, repolarization, and arrhythmia didn't make significant contributions towards the diagnosis, but that CMR findings, family history, biopsy, and depolarization abnormalities fully accounted for the diagnosis. And almost half of these patients, so about 48%, who had definitive diagnosis, so 23 patients, so 11 out of 23 would have actually been grouped in a lower, either borderline or possible, without the utility of cardiac MRI. So it really did add to the diagnosis for these patients. And here again, these are looking at your different aspects. So regional wall motion abnormalities were in 83% of the patients who had definitive diagnosis, and 53% who had borderline. So again, those are the patients that were considered to have it, and only 22% and 16% of the patients who were possible and unaffected. So just goes to show that regional wall motion abnormalities of the RV really does play a role in the diagnosis. And then, again, this just re-highlights that the CMR made the greatest contribution towards your diagnostic score. The only thing was that myocardial fibrosis and the fatty replacement was actually a pretty low yield in children. So, again, like we said, we don't just do the core protocol. We usually do an ARVC protocol, but how much do the other imaging aspects of that ARVC protocol help? Questionable, just because it seems to be the most reliable diagnosis based on the wall motion abnormalities. And then one step further, obviously the difference between 1994 and 2010 was that aspect of the left ventricle. So in 1994, they said the left ventricle has to be normal or pretty darn near normal. And in 2010, they recognized the fact that this can affect both ventricles. This can affect the left side, it can affect just the right side. So this was a paper about LDAC. So this is the left dominant arrhythmogenic cardiomyopathy. And I think I've seen 2 patients. I think they were previously diagnosed, so we haven't diagnosed anyone new this year. But these are 42 patient cohort who had unexplained inferolateral T-wave inversions and LV origin arrhythmias, and they were diagnosed with LDAC. And MRI was used here to really help out. Here you can see this circumferential late gadolinium enhancement. You see this brightness in the middle of the wall. And then here you can see it actually all around the wall. And this is your left-sided ARVC. So without it, when you look at an echo, this is going to look like dilated cardiomyopathy or cardiomyopathy of otherwise unknown etiology. And so this is where MRI really plays into effect, because you can actually delineate the hyperenhanced areas. And this is just another example. And this is just an example that we had at the U. This is one of our patients who so far, everything looks fairly normal. The right side looks fine. There's no areas of akinesis. TAPSE looks okay. There's no significant regurgitation. And the LV looks more or less normal. And then this is the TI Scouts. This is what we do to get the inversion times before our delayed enhancements. And here you can see, and this is from that case from the youth, this is from the girl, who there's that circumferential here on the short axis that looks just bright. And you don't think it's just part of the cavity because it's brighter than the cavity. Then here you can see again in the four-chamber, there's something kind of mid-myocardial or the epicardium of the interventricular septum, kind of on the RV side. And this patient was diagnosed with LDAC. So yeah, so you can just see where MRI kind of plays a role in patients who have ARVC. And then the second case, so this is a 63-year-old male, hypertension, obstructive sleep apnea, alcohol abuse, cervical DJD. He had 3 false MIs in the past. He was sent to the cath lab and he had angiographically normal coronaries. He was referred to cardiology clinic because he had an abnormal echo. And he got the echo because he had this murmur that was noted by his primary care doctor. And he had no symptoms otherwise, and his EKG was fairly unremarkable. So here's EKG. Nothing kind of jumps out at you too much. No. Oh, no. Oh, maybe it won't play. That's not good. Well, this is supposed to be a parational long axis view on echo, and maybe these won't play. So that sucks. Okay, so that sort of defeats the point. But here you can see this is just a still image of the patient, and here they're measuring. This is a different case, so this is an ARVC knee long growth. Now we're just looking at another benefit of MRI. So you can see the interventricular septum is almost 2 compared to the posterior wall, which is 0.8. So they're in the clips that were the parational long that were supposed to have imaging and videos show that there was SAM. Here's your increased velocity through the LVOT. So here you can see it's up to 4. But if we would have been able to see, you can see that the valve doesn't look bacterially sclerotic and it's opening up really well. So it's not aortic stenosis, but there is a gradient. So then you start to think HCM. So based on his findings, he was referred for cardiac MRI for HOCM, and the MRI was really to accurately measure the interventricular septum, because again, your resolution isn't as strong on echo as it is on MRI. So here we do this in our CNA images. We make it end diastole and we measure across the interventricular septum. We usually measure anteroseptum and infraseptum. And this is where you're going to start to have the outflow tract obstruction. Maybe this is taken a little too far. Some of this might be RV myocardium, but regardless, they're getting 22. So even if you bring it in a little bit, it's still going to be measured at greater than 15. And here you can see the infralateral wall is 1.2. So it's thick, but not terribly thick. Here's your CNA images. So again, you can just appreciate that the function here looks okay, but that the interventricular septum looks thick, and even the whole thing looks thick, but really the anterior septum are probably the thickest portions in diastole. Here's your 4-chamber, so you can appreciate that your left atrium looks enlarged. You've got this posterior directed mitral regurgitation jet, and you're starting to think that maybe there is SAM. Now, this isn't the view. You typically are going to look for systolic intermotion of the mitral valve, but you can appreciate a little bit here. Here's your view that you'll look at that. This is your equivalent to your parational long axis. And those of you who came to imaging conference, I think the first conference in September, have probably seen some of these images because they talked about HCM at that time. So again, this posterior directed jet of mitral regurgitation, and you can see just the tips start to lean in towards the interventricular septum, and then you can appreciate the flow acceleration, which is that bright coming across the LVOT and going into the aorta, but yet the leaflets are opening, so you know it's not aortic stenosis. And this patient, so the other aspect with HCM that MRI can really add benefit is looking for late gadolinium enhancement. And why does it matter? Well, most papers looking for LG in any pathology, whether it's AFib, or non-ischemic cardiomyopathy or HCM, late gadolinium enhancement portends a bad outcome compared to somebody who doesn't have any enhancement. So here you're looking for any areas of brightness in the middle of the myocardium. So this one actually looks really good. We didn't really call any LGE. Some of this in the here might just be myocardial crypts. So this one was read as HCM with outflow tract obstruction, evidence of SAM, but no LGE. And so the 2011 guidelines for the diagnosis of HCM incorporate a lot of different aspects, and imaging is obviously the hallmark role. So echo is a class 1 recommendation for those who have suspected, and then you can take that into stress testing, which actually is a 2A, to see if patient's blood pressure goes down, if the symptoms get worse. But then they've actually incorporated cardiac MRI too. Cardiac MRI is a class 1 indication for those who are suspected with HCM who have an echo which is inconclusive for diagnosis. So the first thing you typically go towards is your echo. That's going to show you the gradient, that's going to show you your SAM, that you can kind of measure your septum, but you might miss something on echo. And then patients who may have impact on management. So MRI is beneficial in HCM for both diagnosing, risk stratifying, aided management, and screening for family members. So when we're looking at our cardiac MRIs, what are we looking for the diagnosis of HCM? So we're looking for a wall thickness greater than 15 millimeters, apically displaced papillary muscles, mitral valve leaflet length greater than 30 millimeters, and then myocardial crypts. And I'd have to say, I think sometimes it's still, even with the help of MRI, it's still always sometimes hard to say, is this hypertensive heart disease? Is this somebody with athlete's heart? And then the other pieces are, but they aren't part of the actual diagnostic criteria, looking for systolic anterior motion of the mitral valve and the myocardial fibrosis, both of which can be seen in other pathologies. So patients who have, we had a patient, I think, maybe in August that we had looked at who was inpatient and on the liver transplant list, and she had SAM, and she had a hyperdynamic LV, and I quickly was like, yep, this is HCM, and then she then quickly corrected me and said, nope, this is hyperdynamic state of liver disease, you're wrong. So, yeah. So, like I said, CMR has a role both in the diagnosis as well as looking at the treatment strategies. So, you can kind of go down this algorithm looking to see patients who have a lot of gadolinium. So this is what I was saying, the LG actually plays a role. So those patients who have HCM who don't have late gadolinium enhancement are lower risk. Those who have extensive late gadolinium enhancement have increased risk of sudden cardiac death. And so this can be played into your, who do you put an ICD in, who don't you put an ICD in, and making the actual, and then what do you do, do you do myectomy, do you leave them alone, do you just beta block? So CMR can help with the aspect of treatment as well. And this is just a pyramid that says, obviously, HCM patients, when you get them in your clinic, you can tell them they're probably going to live as long as everybody else. They don't have a higher risk of death per se. Really only the highest risk do you need to worry about, and those are the patients who you have to put the ICD in. So when we're thinking about ICDs, this is when your family history of HCM who have had sudden cardiac death, unexplained syncope, multiple times of non-sustained VT or sustained VT, obviously will be secondary prevention, abnormal blood pressure response, okay, and then massive LVH, so greater than 3 of your interventricular septum is when you're going to say, okay, I think you need an ICD. But actually, this other aspect is this late gadolinium enhancement of greater than 15% of the LV myocardium, which is not as easily to truly say, because this area is very patchy and kind of all over the place, so it's hard to say how much of the myocardium is really being affected by this, versus when you see late gadolinium enhancement of an infarct, you could probably circle it with your cursor and say this is exactly where the infarct is. Late gadolinium enhancement in HCM is usually patchy and very hard to delineate, but if you do suspect that it's greater than 15%, it does portend a worse risk for these patients. And this was just a paper that was more for like a CME purpose, but it looked at the benefit of MRI in HCM, and so the challenges with, obviously patients who have HCM can have the genotype or they can have the phenotype. Patients who have the gene, when you're looking for family history or when you're looking to screen family members, you test them for the gene. Patients who are genotype negative, then you have to use echo as your primary modality or MRI to truly say. And then just the diagnostic challenge, you can see here is hypertrophic obstructive cardiomyopathy. You can also have obstruction without having HCM, or you can have HCM without obstruction. So really, it's not the simplest diagnosis to make in patients, although we seem to think that thick means HCM. That's not always the case. Here you can see the differential diagnosis. So greater than 15 millimeters, which we said was one of the cutoffs, versus 12 to 15. You're looking for your LVOT obstruction. And then here's your differential of what things could be. So like we said, hypertensive heart disease, athlete's hearts, aortic stenosis, you're going to start to get thickened myocardium. So it's somewhat of a challenging diagnosis to make. So here again, they just highlighted the CMR benefits, so the potential utility of CMR in HCM. So for the diagnosis, treatment, and prognosis, one thing for the diagnosis is not all HCM is obviously going to be interventricular septum, and it's going to, you can have your apical form, which is really hard to see the apex of the heart, especially if you don't use contrast during your echo. So this really shows that spade-shaped heart really well on your 2 chambers and even on your 4-chamber. So here it can help you with the diagnosis. You can see truly if there's LVOT obstruction, you can really visualize the SAM much better. You can look for the insertion site of your papillary muscles. You can also find, figure out which your differential is. It'll help break down, make a differential, and so if you think it's LV non-compaction or something, the MRI will help you kind of delineate these. And then treatment-wise, like I said, myectomy or, just beta-blocking medical management, so it'll help with treatment decisions. And then also prognosis, so the biggest thing probably being the late gadolinium enhancement or an intraventricular septum greater than 3. So here was just some images that they had. Here you can see an area of LGE in this patient. You can see the massive hypertrophy of the septum, increased gradient by echo, and again, just a short axis to see that area of hyperenhancement. This just shows that bifid papillary muscle. So you can see 2 distinct heads of the papillary muscle, which you can see in HCM. And again, you see this kind of dagger point CW Doppler through the LVOT. And this again would show your CNA images. So this is apical hokum, so you can see this spade-shaped heart here. And then when you actually do your delayed enhancement, you can see that the hyperenhanced area is kind of right where the hypertrophy is. And this just gives an example of all the different types of papillary muscle anatomy, probably something you never really wanted to know or pay attention to, especially by echo, but by MRI, you can really see kind of where the insertions are with the different types of hypertrophic cardiomyopathy. And then this, again, this just was a summary of the role of LGE and HCM. So like I said before, pretty much in every disease state, I feel like every paper I've read, late gadolinium enhancement portends a worse outcome, and that's not just unique. This is the case, I had showed this back in September when I did my imaging conference, but this was a hypertrophic cardiomyopathy patient whose septum was like, I think it was 8 centimeters. It was massive. This was at UIC where I was, and the patient refused to come in and do anything. So he's like 22-year-old Hispanic kid, and he's like, I feel fine. So we never really saw him again. And then this was a case at the university. Here, again, you can see the walls look thick. You can kind of get an idea of the anterior mitral leaflet of the mitral valve is kind of touching the septum during during systole, sorry. And here you can appreciate the thickness of the heart on the 2-chamber. And then this really, again, your 3-chamber is really kind of the diagnosis to make for the outflow tract obstruction. And then this example, as opposed to the first example that I showed you from here, shows that kind of patchy area of hyperenhancement. So this one might be a little easier to, if you wanted to draw around it and try to delineate how much of the myocardium, but even so, I mean, do you include this? Do you include out here? It's really hard to say what's 15%, but it can be done. And again, this is just the 4-chamber of that. So yeah, so these are just a few cases. So every time we do HCM patient, we do have to do LV mass. And even though it's not necessarily part of the diagnosis, Yeah, so this is just shows the hyperenhanced areas, again, in the walls that are thickest. And again, here, it's probably thickest up here, and so this is where all the lake and the enhancement is. And that's pretty much it. So, like I said, I just wanted to kind of hammer home why, when, why, who cares about MRI, but why you use it and where it can actually add benefit in your patients when you're seeing them in clinic, when you'd refer them to us. Yes, Bill? I don't think they got an ICD because that case was from, nope, they didn't, because that case was from really recent. They were discussing it, but the patient was so reluctant. This, well, oh, the big one, no, he never came back. I don't know, he'd be like, answer his phone, and then when he'd be like, hi, this is UIC, he'd hang up. So he's not dead, but, you know. Not that I know, Chaitan might know more about, you know, that, but, as far as the diagnosis, it's not even in there because it's so patchy and not every patient has it, and those who have the diagnosis who don't necessarily have all the phenotypic findings of it. So it's hard to say. I mean, you would think the more fibrofascial replacement, the worse prognosis, right? And that's it. Thanks, guys. I don't know.